Good morning, welcome to this Lung Cancer Forum. It's always a pleasure to introduce Jim Bishop. Ladies and gentlemen, the Chief Cancer Officer, New South Wales, Jim Bishop.
Welcome everyone, and thanks for putting the time in to come by and talk together about lung cancer. Lung cancer is really a major problem for us all, and what we're attempting to do today is taking data which we think is important, having you look at it, have some discussion about where to from here, and therefore see if we can develop some strategies to change what's the current situation. So it's all about trying this new methodology where patterns of care, information that we have, can be worked upon and change and improvement occur as a result. So this is a bit of an experiment, but we think it will work. If we want to do this with other tumours that need more work, then we'll have a baseline on which to improve what we're doing. So what I'm going to do is just give you an overview of lung cancer. This is just some recent data which Elizabeth Tracy has put together, and I'll give you a little bit of an overview of some of the other broader issues for prevention as well. So these are the results where lung cancer sits in terms of incidence. It remains a high incidence cancer, and the important thing here is that this is a changing environment. In 1973, of course, it was the major cancer in New South Wales. It is, however, the major cause of death and remains so. So that any improvement in death rates, mortality rates, will have a major impact on cancer death rates. So small improvements in survival outcomes, small things that we can do have large impact. So it is really quite important to think how we can engineer those small improvements. If you look at the 5-year survival, again, lung cancer's down the bottom. Our plan here is to work assiduously as we can on the bottom third of this graph, and some of the other things we'll be doing in this sort of series will be focused on some of those low survival cancers. The group in the middle, we think we have the lessons learnt, and it's to do with screening and other issues, but they will also require focused work. So what's happened over the 20-year period, looking back to 1980? Well, there has been some improvement, but I think by anybody's standard we'd say it's modest. So around 10% 5-year survival back in 1980 to 14% as the most recent one. And what's happening to trends? These data look at incidence and mortality rates, and what we're seeing, of course, is a fairly good reduction in incidence and mortality for males, but obviously we're looking at the late uptake of cigarette smoking resulting in increasing incidence in females, still increasing, and now only a levelling off of mortality as the improvements in treatment take effect. So we've looked at survival by sex and age, and what we can see, of course, as with most things in life, women do better. I think that the important thing here is that the age category is also important. So we've seen very poor survivals with older groups, but I think encouraging differences in the younger age groups, and remembering, of course, that the younger age groups are quite important. The degree of spread that the New South Wales Cancer Registry is unique in Australia in that it does record degree of spread. This is not a clinical staging system, but what I call epidemiological staging system, which, however, allows us to look at localised, regional and distant disease in some detail. And what we can see is there are huge lessons there for survivals looking at degree of spread. It's one of the major factors always that influences outcomes. And if you look at the top line, which is on the graph on the left, the localised disease group have about a 30% 5-year survival. Now that's quite different from surgical series. If you look at a surgical series of localised lung cancer, it's between 60 and 75% 5-year survival. So what's the difference? Why is that difference there? And I think we've all got ideas why that's there, But clearly there's an area where we can work that might actually change outcomes dramatically in that group. So we've got a 30% 5-year survival for disease that's quite localised. And I think that's a lesson for us. In the regional disease, and remembering this picks up the broad area of stage 2 and stage 3, and many stage 3 in there. Again, there's been huge advances in the last 10 years with combined modality therapy there, where we know survival can be improved. So that figure there, I think, is one that needs more work. And we also know from the meta-analyses, for example, that best supportive care is a worse outcome for people. You get much better quality of life and much better survival for people that have systemic treatment for lung cancer. So again, we've got improvements in that very challenging group. Here we have the 5-year survivals for all cancers for those that are localised, and again, the point being that lung cancer, while better than the overall survival rates, is still not satisfactory for a localised disease group. Whereas we're seeing, for example, for breast cancer, 97% 5-year survival for localised disease. This equates to the normal population, which might be around 98 or so percent. So in localised breast cancer, we're seeing the outcomes almost the same as if they've not had cancer. Whereas we're seeing huge discrepancies as we move down this slide, and particularly in lung cancer. This looks at the distant metastases, and of course they're dismal. And again, I'd point out breast cancer in this. Breast cancer, metastatic breast cancer has a 5-year survival rate now of 41%. So if you present with metastatic breast cancer, you've got a 41% chance of being alive 5 years later. It's 4% for lung. So I think we've got lessons to learn there. There are a whole range of new therapies for advanced lung cancer, including targeted therapies. And I think we must see some change there. So what are we doing compared to the rest of the world? We're not doing bad. So while I think there are huge challenges for us, everyone's facing up to these challenges around the world. Our results are about the same as Victoria and the US. And the most recent results, which are a little old now from the UK, would suggest that we're doing a lot better than the UK. And I think I'll show you a lung cancer audit in a moment from the UK, which might give us some reason why that might be so. So I think we're doing okay on international standards, that's fine. It's just not good enough. And I think we can clearly see where improvement can be made. Elizabeth Tracy's done a very nice overview of lung cancer, looking at 47,000 cases going back to 1980. And there are a couple of surprising results from this, which I'll just share with you in brief form. One is that there are differences between non-small cell and small cell lung cancer, and that's a surprise in a way because the clinical trial should tell us that the results should be about the same. So if you look at non-small cell lung cancer, the results, the 5-year survival is closer to 15%, but only around 6% for small cell. Now that suggests that in that disease, in the 12% or so that are now small cell lung cancer, we can do better. So these are the results from that overview going back to 1980. And remember, I'm old enough to remember 1980. I don't know how many people here are. But we were all treating small cell lung cancer in 1980. It was the most interesting disease to treat at the time. We weren't treating non-small cell lung cancer at the time, but if you look at the whole experience over that 25-year period, you'd have to say our results in small cell are unsatisfactory as well. So Elizabeth's done a regression model looking at the factors that might be influencing survival, and I haven't got on this slide, but gender is important, and female sex do better, significantly better. But these are the factors that are all less than 0.0001, and so these are factors that we know influence survival. So this provides a clue as to where we can influence things or where we might be able to intervene. So as I said, degree of spread is really important. So the message is clear. Let's see if we can diagnose the cancer earlier. Let's see if we can make sure that those that are diagnosed earlier get world's best practice. Histology is important. As I said, I think we've got a job to do in small cell lung cancer. The period is important, so we have seen that improvement that I showed you. So the most recent period we are doing better, but only by around 4% on the 5-year survival rates. Surprisingly, non-English speaking groups do better. I don't understand that, but it's maybe to do with the way they present. Groups in the highest socioeconomic groups do better than all the other groups, but there's no differences. What's not on this slide is remoteness or where they live or ARIA category. So living in the country is not a bad prognostic sign for lung cancer, and obviously the older age groups do worse. So there's some clues there just based on this very preliminary overlook that suggest that there's some opportunities. The National Lung Cancer Group in the UK have done audits, and this is the result of their 2005 audit. They've looked at 12,000 records of lung cancer patients. In the audit of outcomes there, they were able to look at the histological confirmation that was confirmed in only about 64% of cases. I think that's of concern. They did, however, have a high degree of review at multidisciplinary teams, and remember, we've also done a review of multidisciplinary teams in New South Wales, and we'll be publishing this soon, but I can tell you that about 2/3 of all cancer patients, of incident cancer patients, are reviewed at multidisciplinary teams, and I think that's a very good result. We'll be publishing that shortly. Only 9% in the UK are undergoing resection. That's a pretty low figure. I think that's nothing to do with what best practice would suggest. And only 43% receive anti-cancer treatment, and we know, as I said, that best supportive care is inferior to treatment for advanced disease. We know that combined modality treatment is inferior to lesser treatment for regional stage 3 disease. We know that resections are superior, and now adjuvant chemotherapy has been shown to be of value in localised disease. So the great majority of lung cancer patients should now get treatment, but only 43% in the UK do. You can look at this at their website, and they're just updating that with an update from their most recent audit. Mike Peake, as many of you might know, is the lead clinician for the UK that has kindly given me these data. So I think we've got a lot of lessons there that we have to now tease out today and get ideas about where to from here. I just wanted to give you a paid political announcement, which is about prevention. And while I think we've relied on prevention for lung cancer, and most of the improvements we've seen obviously have been to do with increasing reductions in smoking rates. So just to let you know, these are data from Richard Peto's presentation and analysis of cancer, of smoking-related cancer and other disease in Australia. So he's done one for most of the developed countries. And the results are that smoking will kill 1 in 2 smokers of smoking-related disease. The average years of life loss is 10. About a third occur in middle age, and they'll lose over 20 years of life. And I think what those data also show is that quitting at any age works. So you're never too old to quit. So what's happening with lung cancer prevention? Well, there's a state tobacco plan, and I think the bans have been very useful in Ireland. The early evidence is that it does substantially reduce smoking rates, just the bans in the pubs. We've put unprecedented funding into anti-tobacco ads, and our tracking data would show that they're having a lot of cut-through at the moment. We've got a high recognition of these ads, recall. About 90% of smokers can recall our ads, and they are having influence. We have shown that the intention to quit on smokers, we do an annual smoking survey, which we'll publish shortly, 3 years of those, and that shows that the intention to quit has gone up significantly since these ads have started. About 160,000 or more now have quit. And these are the smoking rates in New South Wales going back to 2004, and it's really the result of a comprehensive program, not just the anti-tobacco ads, but for people we're now down to a 17% smoking rate in adults, and now down to 8% in adolescents. And the 8% figure is for occasional smokers because they don't smoke daily on average, the adolescents. And these are the smoking rates. And I just point out the pink line there, and the pink line is the daily smoking rate. So we're down to just under 14% for all people now as a daily smoking rate. And that's a drop of around 2.4% in 1 year. And we're looking at actually pushing that down further with a whole new series of public communications. But as I said, that we need to have structural downward pressure on smoking, so that's pubs and clubs and all the other things that have been put in place for these last few years. We want more of that, but the ads, I think, help, as well as the enforcement of the new regulations in pubs and clubs. We've just completed a large meta-analysis of all the anti-smoking interventions, which we'll be publishing shortly. And this looks at the interventions that work in terms of pharmacology, and I'll just summarise them briefly here. I think the new anti-smoking agents certainly seem to be very effective, and we're looking forward to those agents being available on the PBS, which they hopefully will be shortly. But I think these interventions work, and as does the quitline, and we'd like to see them more widely used by clinicians. So in conclusion then, lung cancer is the major cause of cancer deaths in New South Wales and around Australia and around the world. So let's be aware that any improvement we can make here has substantial inroads on cancer death rates. The 5-year survival for non-small cell lung cancer in New South Wales in the most recent period is 14.5%, but only 6% for small cell lung cancer. And the mortality is determined by a number of factors that we can identify, and there are many other factors that are not in our database and therefore we've not identified. But the ones we know about are extent of disease, histology, as I've mentioned, period of diagnosis, the socioeconomic group, sex and age, and I think there are some clues in there about how we can certainly move forward. So I think that's about all I've got to say. One last thing just about this particular meeting today is that really the opportunities based on this would be obvious, and they are earlier diagnosis of more localised disease is important, higher resection rates for operable cancers, the application of specific treatment which evidence has shown works more uniformly and more extensively across the state will impact. And we hope to have a better prevention approach with increased amount. Next year we'll be spending over $21 million on cancer prevention, and the great majority of which is in anti-tobacco programs. Thanks very much.